Ladies and gentlemen, it's a real pleasure for me to talk today. I will talk about 4D acquisition input in endovascular AVM treatment. My name is Gentric Jean-Christophe. I work in France, in Brest, northwest of France. And it's a real sadness not to be able to come and to talk to you in person in Moscow. You all aware about the evolution of the imaging in the last year. So we start with the 2D images, beautiful images with a great resolutions. It is like a gold standard, but you have a lot of superposition in this kind of images. And we use something like more than 10 years ago, the 3D images. It's like a non-dynamic volume with multiple projection, but you have sometimes less superposition than 2D because you are able to grab the volume and to rotate and to show a working projection. But you now have access to a new technology. It is the 4D images. So you will add one variable is the time. You will have the one resolution for this variable, and you have a multiple projection and less superpositions thanks to the temporal resolution, as I will try to show you during this talk. If you want to read about it, you have a general, very recent review published in ICENS about all the neurovascular application. Our team and Dr. Julien Ognard published 3 years ago this paper about the 4D DSA and the description, assessment, and reliability in specular margin grading of cerebral AVM. And I like also very much this recent paper in GNES about is more focusing on AVM and analysis of AVMs. And if we go deeper in this paper, you can see here the methodology, with a quick description of the way they worked. So they compare 2D DSA, 3D DSA, and 4D DSA. And each time they use a semi-quantitative scales for readers about and they appreciate the definition of the nidus and the AV chant, arterial feeder, and venous drainage in each modality. And when I read the paper and tried to sum the conclusions, so they found that the rating of the visualization of the nidus was better using the 4D. We will see after the details, but sometimes when the artery and the nidus are a very thin vessel, can be quite difficult, but we will see after. The vessel loops could easily be distinguished for aneurysm, and I think it is a real advantage of the 4D DSA compared to the 2D DSA. Determination of the morphology, caliber, number of fistulous connection is similar to super selective angiograms. To my point of view, it's not so simple. And just one advantage I changed a little bit, and I think it's a real advantage, and maybe Professor Muneya will talk a little bit about this. It is that the display of the origin and course of the vein and the primary veins, even if they are sometimes and quite often very close to the nidus and can benefit from the temporal resolution. It can be so very important, this analysis, to be able to distinguish the primary veins and to adapt especially the venous approach. And for the very small vessels, the resolution of the 2D images tend to stay superior than the 4D images, but it's a lot of matter of post-processing, and we will see that you can also go to the images before the post-processing. Just to talk and show an example. As example, for the small vessel, you can be able, if you have a good injection, to see the vessel. You have this kind of images at the very beginning when just you make the image. And I think the native images are very useful. We'll see why. I will follow the plan description of the 4D DSA technique, which image we can use. We will talk about the inter-observer variability study and the conclusion. Just one word for the technique. It is a rotational angiography without delay. You have two protocols of the Siemens angio suites. You have an extend rotation of 260 degrees. The time of injection is the time of acquisition, and 4D volumes are going to be displayed with up to 30 frames per second in a VRT mode and a time resolved NPR reconstruction. And basically, you are going to work on that. But the native image, don't forget, you can go directly and try to get what they have to say to you. To my point of view, it is very useful images. It is true images before processing with the highest resolution comparable to today images, and it is still a dynamic images, but you are not able to grab them and to work directly on it. Just the workflow for the 4D DSA, and you can see here the reconstruction, the threshold, the geometry, and after you are able to display any volumes at any time for any projection. And you can see here when you work on your workstation, the VRT images are the one you are going to take first, and you will have the option to select the phase you want to focus on, the arterial phase for arterial thinner, pre-nidal anomalies, the nidus, and after you can also have early veins for the primary veins, and maybe late veins, and late timing to be sure that the veins are full of contrast. In fact, you will have the same tools you use to work on a classic 3D. You will be able to select a working projection to focus on one part on the FEM, and you will be able to select which way you want to access the target. So just one thing you have to be aware that the resolution of the VRT images can lead to false fusions. It is the trouble with all the VRT post-processing techniques and a very close structures. You can see here just a control of AVM, temporal AVM I did last week. And you can see you have one feeder from arterial side. It is just here. It is this branch from the cerebral artery, and after you have the vein of Labbé, inferior anastomotic vein, going to the lateral sinus, and you have the 2D images on the right for comparison, and so from this the residual aneurysm, this the residual AVM. Very interesting is one option you can have is to select one working projection, for example, if very useful in this case because it is a rupture case and we want to reach this prenadal aneurysm, and it's like you are working like a when you are coiling one aneurysm, just select the good working projection using this 4D images first. And after just the coiling of the prenadal aneurysm before the treatment of the AVR. The multiplanar analysis is also very interesting. You still have the dynamic characteristic of your injection. You have the ability to work on all planes, but you have to keep in mind that the resolution is a little bit inferior to dynacity or vasocity images if you are used to do this kind of things before treating AVMs. Again, the same AVM, I want to keep the same, just you will see what we are getting from the images. You can see here the temporal AVM, it is like a remnant because she has been embolized in the acute phase a little bit. And you can see that you are able to move the thickness of the slice, you are able to rotate the wall volume, and you are able to select the phase and to stop when you want to stop. Just you want to stop very early for the arterial feeders and you want to stop a little bit after, and you can see here the vein the vein of Labbé is filling, and she gets bigger, and you can see it more easily. And now you have a good idea of the angio-architecture of your IVM. I have 5 minutes left. I just use them to present the work we did in our center. And the goal of our work was an inter-observer variability study to assess the performance of the 4D DSA in the detection and quantification of risk factor and quantitative variables of the AVM, as the number of arterial feeder, the number of draining bed, the Spätzler-Martin grade, and to assess the inter and intra-reader agreement in the use of 4D DSA, and to assess the inter-modality agreement. Now, 2D DSA, even if possibly imperfect, has been used as gold standard for analysis. And we use 10 AVM for our center, and we perform 2D DSA, 4D DSA, and 4D MRA for all. 4 readers are going to read, and 2 readers are going to do it twice for intra-observer agreement. And they are going to complete a reading grid with the detection of risk factor, yes or no, aneurysm, arterial of venous, stenosis, arterial of venous, and also AVM analysis, quantification of the number of aneurysms, of stenosis, of arterial feeders, of vein, and at the end, the Spätzler-Martin grading. I will not show you all the detail, but this kind of image from 4D DSA are going to show intranidal aneurysms here, venous aneurysm here, venous stenosis. And we are going to use this methodology we are going to make a performance study and an agreement study. And you can see here the part of the agreement study with the intermodality, inter-observer and intra-observer. And for the 3 items, we will use the kappa values using the Landis N-core with a poor agreement less than 0, slight agreement 0 to 0.2, fair agreement 0.2 to 0.4, moderate agreement 0.4 to 0.6, substantial agreement 0.6 for 0.8, and almost perfect agreement 0.8 to 1. And just to go briefly in the results, for the DSA was present a good sensitivity in terms of performance for aneurysm detection, better for prenidal aneurysm and venous aneurysm for nidal aneurysms, not a big surprise. A substantial agreement for prenidal and venous aneurysm, but the agreement was moderate for the nidal aneurysm. And concerning the aneurysm detection, the inter and intra-observer agreement were moderate to substantial, and it is comparable to the 2D DSA, sorry. Concerning the detection of stenosis, an excellent sensitivity and specificity in terms of performance from the arterial side, and a lack of specificity on the venous side. We will talk it a little bit later, but I think the filling of the vein and the anatomic feature is very important to understand. Concerning for the DSA, for the stenosis detection, a moderate to substantial agreement on the arterial side, and again, more difficulty on the venous side with a poor agreement and a slight agreement for the intermodality. So we will talk about after. A good result on the arterial side for 4D DSA, inter-observer agreement comparable to 2D DSA, concerning the quantification of the number of stenosis. So for the number of venous stenosis, we found a fair correlation with 2D DSA, a slight intermodality agreement, and a poor inter-observer agreement. For the DSA, concerning the number of feeders, vein and Spätzler-Martin grade, we find a good correlation with the 2D DSA and moderate to substantial agreement with 2D DSA, and a slight agreement for number of arterial feeder. I think the matter here is the definition of what is a feeder. It is what you see, what you can use, and it is always this kind of things when we talk about AVM, enjeu architecture analysis. We also found a moderate to fair agreement for the draining vane and the Spencer-Martin grade. Just for the Venus analysis, it's very interesting, especially very close to the nidus. In flow competition, analysis can be difficult, especially on VRT images. Use the latest phase to be sure of the filling of the veins and could be interesting in the Venus approach. And you can see here the image you can have. Is it a false stenosis you have here on the VRT images? But just wait for the late fillings and you can see that these veins do not present any stenosis. But at the junction of the large lateral sinus, you can have this kind of image because you have a flow competition and it is not a stenosis, it is just that the vein is touching the sinus. Just to conclude, 4D DSA can be very useful in many situations. Present some traps we are not used to deal with, especially the false venous stenosis and the small vessels. The workflow can be used routinely, and the irradiation is about 6% of your geographic diagnostic exams. 2D DSA provide valuable complementary time result information in these cases and cannot be replaced by a single 4D dataset. Thank you very much.